I've invited Dr. Malcolm Roth to join us today to discuss the evidence around use of wetting solution for breast reduction. Dr. Roth is currently Chief of the Division of Plastic Surgery at Albany Medical Center and also the current President of the American Society of Plastic Surgeons. Welcome, Malcolm.
Good to be here with you.
As you know, the evidence from a couple of studies is pretty strong that use of wetting solution decreases blood loss and decreases the need for transfusion. And as we've seen from the analysis of the maintenance of certification data that the board has, despite this evidence, about a third of the surgeons are using wetting solutions 100% of the time. So tell us what your current practice is and what your feeling is about the evidence.
Sure. So I've been in practice for 23 years, and breast reduction is, I think, the procedure that I did more of than anything else during my training. And that's how I grew up, not using wetting solution. It boils down to an inexperienced pair of hands and old habits. If you don't have problems or you're not aware of any problems in your practice, change can be something that is slow or difficult, or it may not be necessary. You haven't needed transfusion. You might ask yourself, well, why would I add a step?
You raise an interesting question. It wasn't specified in those studies whether the wetting solution was used with a surgeon using scalpel or a surgeon using electrocautery.
One of the other issues is when you do breast reduction surgery, certainly it's a bilateral operation in most cases, and having a sense of how much tissue you're removing and whether the wetting solution might make you less comfortable with the amount of glandular resection you're doing on one side, both sides, trying to make sure that you have a symmetrical outcome.
It's interesting. I think one of the approaches for use of the wetting solution is to use it the way we do liposuction, which is in the gland. And there's others, the technique I specifically use is deliberately behind the gland. So I'm really just trying to get at the perforators coming up through the pec, not to distort the gland so much, but just to make sure that those feeding vessels are somewhat vasoconstricted, which would have a different impact on the breast than if I was doing a complete breast infiltration the way you might do for liposuction breast reduction. So it'd be different.
For me to hear and read about your experience doesn't give me the same opportunity to be in the operating room assisting you or working with you, feeling the tissues and knowing how that's going to feel for me in the operating room and assessing what that woman's post-operative volume and symmetry are going to be.
Have you done some liposuction breast reductions?
I have.
Yeah, because certainly then when you infiltrate the breast, you are making it truly tumescent to the point of being tense, which is completely different from the way I personally use the wetting solution behind the gland. I can understand that if the breast itself was truly tumescent, that would make it very difficult to judge what the resection is to be.
What's the usual volume that you are infiltrating per breast?
Maybe about 150 cc's, 150 cc's. Understanding those variables, is it cautery, is it knife, is it laser, is it glandular infiltration, is it retroglandular infiltration? Those are all variables that probably these studies in the past have not controlled for.
And I think it is a good question to be asked, and perhaps moving forward with more data points in a prospective study, we can have people more comfortable in considering what the evidence appears to be showing. Some of these old dogs, like the one you're looking at, might be more willing to switch over when that data is a little bit more clear.
Yeah. Well, I thank you very much for joining us, and I'm sure our readers will appreciate your thoughtful comments.
Okay, thank you very much.